So women veterans are making up almost 20% of the force today, and people don't really realize how important it is to really focus on women's issues, and that they are part of the essential force that protects this country every day, both domestically and overseas. So many women are involved also in the federal government and in many other branches of our country that allow you to sleep at night. And so I'm going to start with introducing our panelists. Dr. Sarada Deshpande is a board-certified internist and women's health medical director at Jesse Brown VA Medical Center. Dr. Deshpande provides leadership and guidance with a collaborative approach across multiple clinical services, such as primary care, specialty care, gynecology, radiology, mental health, emergency medicine, physical therapy, whole health, social work, and community care for the departments throughout the VA. She coordinates those and helps with her leadership. She is an integral part of the Jesse Brown VA's mission to provide excellent, high quality, and evidence-based care to women veterans. Hello, Dr. Deshpande.
Hello, sir. Thank you. Good afternoon.
Hi. We also have Chasitie Levesque. She is with the Jesse Brown VA Medical Center, has her doctorate from the University of Illinois, go U of I, and is a clinical pharmacy specialist, providing care to women veterans and veterans in general in multiple areas, including primary care, smoking cessation, and anticoagulation clinics. She created one of the first women's health clinical pharmacy services in 2005, which was followed by the initiation of the Chicago Heights VA clinical pharmacy services in 2006. In 2015, Dr. Levesque joined the Veterans Integrated Services Network, which is VISN, VISN 12, as the Network Women Veterans Program Manager. This is actually the first person to do this as a pharmacist within the VA system. And she's also a clinical program manager. She is a member of several national VA programs. We would be on for a couple of hours if we want to list all of them, but she's very, very active, least to say. Asya Brodsky, and I'm hoping to pronounce the first name right, Asya. And she's a licensed clinical social worker, which is close to my heart. My mother was a social worker from her age of 21 to 91. So she in New York City, but she was really involved. She also, works with addiction medicine for alcohol and drug counseling. She has a CST as well, is a social worker, and who has been the Women's Veterans Program Manager at the Jesse Brown VA Medical Center since March of 2021. In her role, Asya serves as an advocate for women veterans and is responsible for the administration, monitoring, and evaluation of the Women Veterans Health Program. Today's discussion, since we have these three highly qualified people to talk about this subject, is Jesse Brown VA's Women's Health Breast Cancer Awareness. As I mentioned in the opening, this is Breast Cancer Awareness Month. So I'm going to actually move to Chasitie first, and I'm going to ask you a question. I want you to tell us about the women veterans population and priority areas for the VA.
Well, thank you. And let me just first say I'm really excited to be here and share the great things we're working on in VA, and particularly at Jesse Brown. The first thing I want to share with you all is that we now know there are more than 2 million women veterans living in the United States. And of those 2 million veterans, we have more than 900,000 enrolled for VHA services. We want more to enroll, so please let's spread the word through this opportunity. I want to share with you that women are the fastest growing population in VA, and we tout that everywhere we go with our leadership as we work on expanding our programs. We know there's more male veterans, but women are the fastest growing population, and so that's really exciting. I want to point out that we know our women are younger than their male counterparts. They're more racially diverse. And there's a higher proportion of them that have service-connected disabilities when we compare them to male veterans. And what that means to us is that we need to build out programming to support this population. So whether she's service-connected for chronic pain or PTSD, we want to make sure we have what's needed to support her. And the last thing I really want to drill home about our women veterans are they are often the core of their families. They are caretakers to their children, to their spouses, to their parents, to their friends, and they often put themselves last. So it's our job to make sure that we are really supporting them and providing flexible ways for them to access the healthcare. When I think of top priorities, there are many priorities, but hands down, the top priorities probably include our comprehensive and quality care that we want to provide them. We want them to have one provider where she can get her primary care, her chronic disease, her gender-specific care, such as mammography, which we're talking about breast cancer awareness, so that she's not having to see multiple providers. We want that one provider to take care of her. Our next priority area probably includes reproductive health. And when we think of reproductive health, we think of the life cycle of our women veterans. So in her younger years, we're thinking of contraception care, maybe preconception care. Infertility services may be needed. Pregnancy. We're not delivering babies in the VA yet, but we do support our patients and pay for their services in the community. We do have maternity care coordinators that follow our women through their pregnancy, as well as 1 year postpartum, which could be a vulnerable time after delivering. So we want to make sure we're helping them access care if they need anything. And then as that cycle continues through life, we transition to menopause. And so I would also share that gynecology has been a big area that we have been working on increasing in VA. Jesse Brown's done an outstanding job with increasing their presence of gynecology for our women veterans. And then the next priority area I want to share with you is care coordination. Care coordination is essential for our women veterans. I just mentioned that when patients are pregnant, they're getting that care in the community. So we want care coordinators to help them navigate that. And care coordination is essential with breast health. So with getting a mammogram, it could be a little overwhelming getting a mammogram, and it's certainly overwhelming if you find out that there's some unfavorable, news where you need more testing. And so those care coordinators are essential to help our patients navigate the healthcare system and make sure we're getting records in the VA so that we're having great communication with the patients.
Comprehensive program, and it sounds very well integrated. There are a lot of different issues that come up in that, and where women haven't really received enough attention, in cardiovascular care, in care general, right? So, but Asya, what services are offered in the women's clinic? That's really interesting that they're
Sure.
building that section out.
Yes, so we definitely are growing and we're proud of the care that we provide. So we have a Model 3 clinic, which is called a comprehensive health center. We have a clinic that's specifically designated for women. It ensures privacy and dignity. It's a separate space from primary care. And so the things that we offer when we think about comprehensive care, we're talking about care for both acute and chronic illnesses, as well as gender-specific care, some of the things that Dr. Levesque was talking about. So we're talking about, cervical cancer screening, preventative care. We're talking about breast cancer screenings, all gender-specific to someone who identifies as female. And then again, as Dr. Levesque said, we also have care coordination services. We're proud of having a very robust mental health and social work team. We've got a full-time social worker within the clinic. We have two specialty care programs adjacent and connected to our clinic, which is eating disorders and addiction treatment. We also are very proud to have peer support in our clinic. So when women veterans feel like they can't open up to someone who hasn't walked the walk and been in their shoes, we have a peer that very much supports the care that they receive and helps them link to services. And then mental health, we've got a full-time mental health psychiatrist in the clinic. We have 2 full-time providers, one working in something called PCMHI, which is primary care mental health integration, which means that if someone is seen in primary care and it seems like there may be an issue and they need to talk to someone that day, they're able to be linked and connected to care. And then we also have someone within our clinic embedded who's part of the outpatient mental health team, so that they can be seen for longer term care as needed, even if it's episodic. And we're very proud of this because we know women are affected by additional stressors and may present with needs around psychosocial support. And then, when I talk about comprehensive care, we've got PACT teams. So PACT stands for Patient Aligned Care Teams. And so we've got a provider working with them. We've got 3 MDs in our clinic offering comprehensive primary care. We have a nurse connected, and this is how they sort of coordinate services when it comes to documentation, when it comes to preventative shots, things like that. We have an MSA, which is our front desk staff to help. We've got LPNs that are wonderful and that they do triage. And we're also very proud. And then, of course, as Dr. Levesque mentioned, we've got gynecology and we've got pharmacy to help provide care. And we're very proud of the fact that every provider within our clinic is female identified to be able to relate to the population.
Oh, fantastic. That's really very incredible. I mean, it sounds like you're really meeting women's needs where they are. And I have an incredible leader coming on right now, Sarada. I'm going to ask you a question. Because I was really impressed by your background, what you've been doing at the Jesse Brown VA. It sounds like I'm not sure why you can even be here unless you have 10 clones. I'm seeing one of the clones here.
Right. Thank you so much for inviting all of us. And this is a great occasion to spread the word for the breast cancer screening. I just want to add a couple of points to Asya Brodsky's, introduction to our teams. I do want to mention, we have a full-time gynecology service here. We do major surgeries in our hospital, and one of our gynecologists is Urogyn trained, and we are planning to start another specialized procedures called urodynamics pretty soon. So I just want to add that there, and coming to breast cancer screening, and as I mentioned, this is a great time to discuss about it. As we all know, breast cancer, if detected very early, it's curable. We do not have mammograms right now in our VA, but we do have, as Asya Brodsky mentioned and Dr. Levesque, Chasitie mentioned, we do have a great team here, including a mammography care coordinator, as well as a great community care department, where the provider, the clinician, orders the mammograms, and the community care reaches out to the patients and the outside vendors and making sure that this gets done. I do want to talk a little bit about screening, and when we talk about screening, we are talking about doing tests to find things that the patients do not have any symptoms yet, like, for example, with the breast cancer. And this screening, the best way to screen for breast cancer is mammograms. This is been there for age-old techniques, and it is a little uncomfortable. A mammogram is essentially an X-ray where, the breast is placed in between 2 views and we take a shot. It's a little uncomfortable, but it's not extremely painful. And this is the best way to detect breast cancer early on. And as I mentioned earlier, if we detect it early, it is curable. And when we talk about screening guidelines, there are several societies and several expert teams who recommend different things for screening. But in general, we recommend that every woman should discuss with their primary care provider at the age of 40 to start talking about mammograms. And we follow American Cancer Society guidelines in our VA system. And mind you, these guidelines are applicable only to average risk women. By that, I mean, they do not have any other high risk factors for breast cancer, like known history of breast cancer already, or a strong family history of breast cancer, or a known history of a gene mutation in the family. And those are very different guidelines than the one I'm talking about today. It's a regular average risk women should start talking about mammograms at the age of 40 and start getting mammograms every year from 45 till 54, and after 54 every other year. And after 75, if the woman is doing well without any health medical issues and is going to live for at least another 10 years or so, we continue to do the mammograms. However, recently another expert society came up and said there may not be much value after 75, but we need to take into consideration patient factors, patient preference, and making sure these are average risk women when we talk about breast cancer screening. I do want to talk a little bit about what we do in our clinic when, with the primary care providers. We have primary care providers, as Asya Brodsky mentioned, at the main facility, as well as in our community-based outpatient clinics. And all these women's health providers, they're all called designated women's health providers. That means they have to have certain kind of training, certain number of credits every 2 years for us to retain that designation. So the main focus is with women's health issues like cervical cancer, pap smears, or mammograms and things like that. So we are very fortunate. We have at the main facility, we have 3 MDs, and in our CBOX, every facility has 2 designated women's health providers. So the first step for any woman who is listening and seeing us today is to reach out to their primary care providers to discuss about the mammograms if they are 40, or if they're already getting mammograms, to reach out to them to get an order for another mammogram. I want to talk a little bit about breast exams too in this portion for the screening, because this is a common thing that all women ask me about. Again, when we make guidelines, we talk only about average risk women, not high risk patients, as I mentioned early on. High risk patients are very different. So for average risk women, we do not recommend any self breast examinations or any breast examinations by a clinical provider. There's a lot of data showing that it might lead to false positive tests and unnecessary biopsies and things like that. But having said that, if you are hearing me, you see a change in your breast, any changes, any skin changes, color changes, size or nipple discharge or anything, please reach out to your providers. As I mentioned, as Asya Brodsky mentioned, we have a great team here, and one of our main person in this whole mammogram thing is our mammography care coordinator, who actually acts as a liaison between the patient, between the facility, between the community care and things like that. As Chasitie Levesque mentioned early on, getting a mammogram itself is stressful. On top of that, we are sending people out, but we have a great way of tracking all these orders, all these patients. And if there is any abnormality in the initial screening mammogram, the radiologists, the doctors who read these mammograms might recommend further testing, which includes a diagnostic mammogram or an ultrasound. So my request to all the women out there is to reach out to your doctors or nurse practitioners or your providers, ask for a mammogram order, and please get your mammograms in time, because we know there is so much data that's been shown and so many advances in breast cancer now. Even if the breast cancer is like found in a later stage, the outcomes are much, much better now. And the best way to detect all of this is starting with the mammogram again. I think I made my pitch for mammograms. I'm not sure if you have any questions on this screening.
I was part of Operation Iraqi Freedom and Enduring Freedom, and one of the things I thought about, just a couple of days ago, is the timing of things. And time goes by very, very quickly.
Exactly.
And that was 2003, 2004, 2005, 2007, and we are almost 20 years later, right at this point. So those people who are there are going into their 40s, the women who are serving, and this is the time that they really need to be critically thinking about this. and making sure that they are, going for the proper care and guidance. Excellent, Dr. Deshpande. So how is a woman veteran able to be screened for breast cancer, Isa?
Sorry, I was checking to make sure I wasn't on mute. Like Dr. Deshpande said, right now we don't have the equipment to be able to complete screening on site, but that is something that we plan to obtain within the facility, and we're very proud of this. So we will have a mammography suite within Jesse Brown. And so right now, a woman veteran is able to be screened by being connected to our mammography coordinator, after the primary care provider, being connected to the mammography coordinator, and through community care. So community care will work with veterans to identify a location, a time, and a date for a mammography visit. And then those visits are reviewed to make sure that providers are alerted of any significant findings and notified within a set amount of time. We track this carefully because we know the vital importance of making sure that someone has results, especially abnormal results, within a given period. And so then our mammography coordinator reviews all of these breast imaging results, including biopsies, and she follows up with veterans and providers after a provider first notifies a veteran of what those results are. Our coordinator is full-time. She's responsible for assisting with orders and appointment scheduling. And like Dr. Deshpande said, serves as a liaison for veterans in the community. So our mammography coordinator is there full-time. Our community care mammography coordinator is also there full-time. And this is quite unique to a lot of the facilities within our region, within our VISN. And we're very proud of having that available. Yes.
Oh, fantastic. Sarada, there's one thing, how has breast cancer screening been expanded? Because I know there is a nexus with the Service Act, and that there are other things that are going on that sort of highlight that. So can you explain that a little bit?
Yeah, absolutely. The Service Act was established to make sure that women veterans who are deployed to various places during certain time periods might have been exposed to toxic chemicals. So as of today, we do not have a direct evidence that this exposure causes breast cancer. There's a lot more research going on, and the national and central office is working with subject matter experts in that, and they came out with these guidelines for all women to be screened for breast cancer if they are exposed to these chemicals. So that screening includes, number one, where they served, what is the time period they served. Then number two, their own personal risk factors, like if they already have cancer, or if they have a family history, as I mentioned earlier, or if they have a genetic mutation in there. All of this are pulled into one algorithm, and that actually tells us what needs to be done next. If somebody has a strong family history already and they are exposed to these chemicals, then we do have another great service in the VA that is called genomic service. They are not located in our facility, but they are located out in Utah, and they do virtual appointments for us. So, and depending on this risk calculation, the provider and the women veteran, it's a discussion between them to see what needs to be done. If they're already at 40 and the algorithm says that patient qualifies for a mammogram, it's no brainer, because at 40 we start screening anyway. But if the woman is less than 30, the things are a little different, because younger women have dense breast tissue called more milk glands, and we do not recommend mammograms less than 30, but if they have a strong family history and a strong chemical exposure, and the patient and the woman veteran feels that she would need some kind of screening, then we will order the mammograms, because we updated our orders to make that notation whether they're exposed to toxic chemicals or not. So we kind of know, and don't get charged for these things, So this Service Act is like, we just started doing that recently, and we are trying to reach out. And one of our coordinators is actually helping us out with this service at screening. She pulls a list of patients who needs to be screened and tries to get appointments for them in the clinics. And and it also takes a good 5 to 10 minutes of questionnaire for the patient. I mean, for the woman veteran to answer. Then we can decide whether that woman veteran needs a mammogram or not. The reason I want to emphasize in very young women is if their tissue is very dense, there can be a chance for false positives that can lead to unnecessary biopsies, unnecessary testing too. So this is a very intimate discussion, basically between the provider and the patient. After they
great. Okay, thank you very much, Sister Spotty. Well, we're actually running out of time.
Oh, sorry.
I'm going to turn to Chasitie, and I want you to tell us, how can someone access VA services for breast cancer screening and other gender-specific screenings? I know there's a phone number, and
Yes. I want to share with you, for our patients at Jesse Brown or in the Chicagoland area, please call us at 312-569-8387. You also can reach out to our national help desk or help customer service that's open 24/7, and it's 1-855-VA-WOMEN or 1-855-829-6636.
Oh, fantastic. And the Jesse Brown Women's Clinic number is 312-569-6246. And also there's an assist linkage at JB with a person is Asya. I guess I can say it. Asya Brodsky at 312-569-5933.